thing that is known also about the dying process, there's actually a lot known about the dying process, mainly in end-stage cancer patients, is that it's almost nature's way of making death less uncomfortable for someone by having the patient withdraw a little bit. They become a little less conscious. They stop taking food. They stop drinking fluids. And they're just a little unconscious. It's almost nature's way of keeping people comfortable. Because once you give people fluids, either artificially or drinking, mainly artificially, what happens is people are a little more awake. They can feel the pain of their metastatic cancer. There's a very common feeling of drowning when people are hydrated with an IV who are in that situation. The fluids are back up, mucus builds up, and people feel like they are drowning. That is the worst part of dying, is being short of breath and feeling like you're choking, feeling like you're being asphyxiated. It's a horrible thing. So what the researchers in oncology have found is that they don't push or urge people to get an intravenous or to get tube feedings, which we'll talk about in a second, because essentially it's prolonging death. It's not prolonging life. What is a couple of weeks of tube feeding going to do for us in the long term? Well, in reality, what patients and families say is, well, I just want to get some nutrition into him so we can get him back to whatever position so he can go home. That's only reasonable, and that's only reality when the patient's not late-stage disease, when the patient is not terminal. We are not realistic because it's so painful. It's very painful to accept that your loved one is dying. It's one of the worst things that can happen to you, especially if that person is a child. But I think that what happens is it's so awful, and the decisions that need to be made at that time are so unpleasant and so difficult that people are not realistic. No one can expect you to know different scenarios of how people die so that you can give your opinion. Well, when this happens, I want this. When this happens, I want that. No one can expect you to know those things. But for people to be realistic is one of my greatest wishes. When someone is in the dying process, when someone has a cardiopulmonary arrest, they are not healthy to start with. Now, what is artificial nutrition and hydration? That simply means, artificial hydration means that an intravenous with fluids is placed in a vein. Anyone who's had that knows it's uncomfortable, sometimes very uncomfortable, but it does hydrate the patient. And artificial feeding, artificial nutrition is a tube that is surgically put in through the stomach and down the throat by an endoscope, by a gastroenterologist. And then the food is pumped down into that tube. That in itself has its own problems. It's not an entirely safe procedure, although usually it goes just fine. But it is not comfortable having a tube coming up out of your stomach and out of your mouth, or out of your nose. That is not comfortable, but that's what it is. It's a tube from your stomach or a little past your stomach, coming up and coming out of your nose. Or in the case of a percutaneous one, it's coming out of the skin. So there's always the risk of infection, and there's the risk of it being pulled out, and this and that. One of the barriers of this type of stuff is people think, well, I can't deny my family member fluids. I can't starve my mother. I can't let my husband be dehydrated. So people kind of get attached to this intravenous nutrition, this artificial nutrition and hydration stuff, because they feel like they're they're not loving their person, they're not loving their family member adequately by not taking care of them, by not feeding and giving them fluids. In fact, there's nothing wrong with giving people fluids by mouth. They can still have that if the patient wants it. And the same with food, they can still eat. We're just talking about artificial means of nutrition and hydration. What a lot of people don't realize is when we put a tube in, it's called a PEG, percutaneous endoscopic gastrostomy tube, just a tube coming out of the skin. People think, well, that'll get him nourished a little bit so he'll be able to come home and we'll have a little more time. It doesn't usually work that way. There are complications of putting these tubes in. Many people are told in a hospital setting, for example, that if a person is aspirating, meaning if they have poor swallowing function so that food and saliva goes into the lungs instead of in the stomach, if they get a PEG tube, that will solve that problem. That is completely false. There is actually more aspiration pneumonia with a PEG tube than there is without a PEG tube. So if you ever hear it from someone, that is false. What happens in the aspiration is either food or mucus or saliva goes into the lungs. You've seen people cough when they eat, when they're in that kind of a setting, and it causes pneumonia. You probably heard the old saying, pneumonia is the old man's friend or the dying man's friend. It's the reason that was said is if you allow someone to die naturally, if they have pneumonia, and you just take care of their oxygen needs and you give them pain relief and you give them comfort, that it's a much, much easier way to die than it is to die with pneumonia, intravenous antibiotics, intravenous fluids, a breathing tube down your throat. So we really need to think about what's the reality of the situation before we say, yeah, let's do this, let's do that. Usually, or frequently I should say, artificial nutrition and hydration are futile. They have no value. If you give someone an extra few days, but they're attached to 1 million tubes and then they start to get pressure sores and things like that, I wouldn't want those extra few days. Because to me, that's prolongation of dying and not prolongation of living. When I can have my life prolonged, I'm talking about quality of life, not just hours. And I think that's how most people feel, but it just needs to be talked about more. That what we mean is quality life versus life. There's different meanings to that. And there's a good death, and there's a bad death. Really, people say that was a good death, you know? He didn't suffer at all. It was quiet. It was gentle. He had his loved ones around him. There's a really awesome book on the subject called Dying Well by a doctor named Ira Byock, B-Y-O-C-K. And this is a hospice doctor who's one of the funniest guys. His book is hysterical, and it's talking about dying. The book is hysterical, so you're laughing on one side, you're crying on the other. And this is a book talking about what does dying well look like. And he tells the story of his patients and how beautiful the experience really was. His patients and our patients who are allowed to die naturally have the chance to come to some closure with their loved ones. There are very often unresolved relationship issues. One person's been mad at her sister for 5 years. Well, now she's dying. That gives you the opportunity, if you know that you're going to die and you prepare for it and you want to have a quote-unquote good death, many times you'd want to call that sister and say, you know what, whatever it was, I'm getting older or I'm dying and I want you to know I love you despite the fight we had. And the same goes for estranged children. It's a very common thing. When a child or a loved one is included in the discussion when you're writing up your advanced directives, you are doing them a tremendous favor. You are preventing them from having to suffer thinking, what would mom want? What would dad want? You told them what you want when you filled out an advance directive and you shared the information with them. There's nothing more horrible than seeing a bunch of crying family members standing around a bed thinking, God, what would she want us to do? What would she want us to do? And then the decisions are that much harder. To make the decision at that point to let the person go is so awful. It is such a difficult decision, and it doesn't have to be. You're, in a way, giving them a break, giving your family a break when you fill out your directive and you discuss it with them. It shouldn't come as a surprise to them. They don't have to make the tough decisions. But the ones that do, it's really often the most loving decisions. To let go of someone gently is a much harder decision than it is to say, yeah, send them to the hospital, start some antibiotics, give them a transfusion, because the emotionality of the whole thing is lost in the technical portion of it. It's so much easier to deal with the day-to-day, okay, how was his blood count today, and what's his oxygen level today? That's much easier than actually dealing with what's really happening. What's really happening is you're losing your mother, you're losing your sister, you're losing your father. That's much harder to deal with. But when someone really loves you, they have to be willing to make those tough decisions. And you are doing them a big favor by helping them along with that. Now then there's the other, one of the two barriers that I wanted to talk about is one is, what if, this happens actually not at all infrequently, the grandson from California comes in when grandma is in her late stages of cancer, and she doesn't have a living will, and he's the nearest relative or something, and he demands that everything be done. Well, what is everything? What does it mean, and what will we get out of that? By everything done, they usually mean, I want you to put her on a respirator, I want you to have IV fluids, I want you to have artificial nutrition, and I want you to continue to give them chemotherapy and blood transfusions and antibiotics. Sometimes it's that relative that hasn't been around and actually really feels very guilty because they haven't been there for their loved one. And that guilt drives people to make decisions that seem like they're more involved, that seems like they love the person more. But the real, true, tough decision is letting someone you love go. That's much more tough. We frequently have problems with family members who, there is a living will, but the family member comes in from Oshkosh and says, no, you have to do this, you have to do that. Well, sometimes there's guilt involved. Sometimes there's religion involved. That's one of the other barriers. A lot of people feel like, well, I'm not going to interfere with God's work. God tells me when I'll die and when I don't. And a lot of people feel that way. I would submit that by doing these things, we're interfering with God's will. We're interfering with nature's process. You could look at that several ways. So those are the big barriers, but also the people are very unrealistic because it's so painful to be realistic in this kind of a setting. I don't know, if I had $1 for every time someone told me, oh, he'll make it, he's strong, he's a fighter. I hear that from everybody. Everybody supposedly is a fighter. Sometimes there's no doubt that a good attitude and a strong will to live helps people live longer or live better quality or surprises their doctors. That's a wonderful thing. But there's that, and then there's the 95% of the time where this fighter is fighting against something that we have no control over. It's above us. Cancer's all over the body. The person is either very elderly or very debilitated. That's beyond our control. Doctors certainly can't do everything. And nature is going to do what nature's going to do, no matter what we say. And that's hard for people as well. Everyone thinks their loved one is a fighter. Really, it's a very common thing that I hear, that we all hear.